Everybody, I am wearing a mask, so I don't get you sick when I cough. All right, so my name is Maria Ortiz, co-chair of Housing, Health and Human Services, and this is our monthly meeting. We are in October 2024. First, I guess we can go around the room really quickly and do introductions, and then I will let Dolores do this. We'll start here.
Hi, Roberta Barnett, member of the committee.
Hello, everybody, Kevin Collins.
Rachel Lee, committee member. Katie Stokes.
Raul Larios, member, and I live in Hell's Kitchen.
And online, I'm sorry, Dolores. Online,
Online, Paul Ames, public member.
Betty McIntosh, member of the committee.
yes, you did it and you weren't on mute.
Well done. And I'm Dolores Rubin, member of the committee. And so on behalf of Maria, who is the co-chair of the committee, I'm going to read the statement. Greetings and welcome to the Housing, Health and Human Services Committee meeting for October. MCB4 does have a hybrid policy. It can be found on our website. Board members are expected to attend meetings in person unless they have a disability or an extraordinary circumstance. Excused members and members of the public will still be able to participate virtually. Members who are joining via Zoom must leave their cameras on, and as we just introduced, we have two of our committee members that are attending virtually. The meeting is being streamed live on our YouTube channel, and a transcript is being recorded. And with that, we can open the meeting.
The first item on the agenda is Ryan Clinton Community Health Center. Ryan.
Chelsea.
Ryan Chelsea Clinton Community Health Center. And because I work there, I cannot leave this part of the meeting.
So I will help out.
So Dolores is my co-chair for this evening.
And I'd like to welcome the new, well, not so new anymore, executive director. And the rest of the team, and I'd like for you to just introduce yourselves and let us know what it is that you're here to visit the community board about.
I'm Serena Jean-Louis. I'm the executive director of Ryan Chelsea Clinton. I'm very happy to be here.
William Arboleda, deputy director of Chelsea. It's great to see everybody again.
Good evening, everyone. My name is Carla Russos, Community Relations Coordinator, Ryan Chelsea Clinton.
Great. And as we see that you are here to talk about budget needs, this is our budget season. So for those that are watching virtually, this is the time of year that the community boards have an opportunity to advocate for specific needs across different groups to the various agencies. Let's just go backwards. The various agencies that may be able to provide that in our budget. And so we are going to hear from Ryan Chelsea Clinton on their operations and perhaps some of the things that they may need.
Thank you. Okay, so if you can go to the next slide.
So, Ryan Chelsea Clinton is an independent affiliate of Ryan Health, which in 1967 was established. We were the third, as many of you know, we were the third community health center in the nation. First was Rural Center, Mississippi, whose name I always forget. Second one was Fenway Health in Boston, and we were the third. We served first the Upper West Side of Manhattan. And in 1977, we became an independent, donated controlled health center, and were renamed for William F. Ryan, who was a congressman in the district, also a civil rights and healthcare activist. He coined the term "healthcare is a right, not a privilege." That is youth and is our mission and our vision today. So we are part of 18 health centers throughout Manhattan, currently serving over 50,000 patients. But we are, like I said, an independent affiliate of Ryan Health, and we meet the needs of this neighborhood, Hell's Kitchen, Chelsea, and basically CB4. And we have over 15,000 registered patients. This year, we're slated to have over 55,000 unique patient visits. Slide.
Next slide.
So we're open for the community. We're open, we have 3 nights that we're open until 7 PM. That's Monday, Tuesday, and Thursday. Our hours are 8:30 to 7 PM. Wednesdays and Fridays, we're open from 8:30 to 4:30, and we're open from fall to the beginning of the summer, September to June, 9:30 to 1, on alternating Saturdays. As you all know, we're located on 645 10th Avenue, which is between 45th and 46th Street, just down the street from Target, or what used to be the Hess, right?
For those that remember.
Yes. We are looking to expand our hours, sometimes we have resource challenges, but we believe that the capacity is there, and the demand is there. If the capacity were there, the demand will be met. So that's something in the future to look at, opening, increasing our hours. Next slide. So, as a community health center and a fairly qualified health center, we serve any patients regardless of their ability to pay. So we take all insurances, private, take Medicaid, Medicare, but we also take the uninsured. All right, and we put them on a sliding fee scale, so it doesn't matter if they're underinsured, uninsured, not able to be insured. As many undocumented individuals are, we will put them on a sliding fee scale, and they will pay as little as $35 per visit, depending on their family size and income. And we also provide a low-cost pharmacy plan for individuals, again, who are uninsured or underinsured. Next slide. So who do we serve? Right, so our catchment area is 14th Street all the way up to 77th Street. Basically, we cover all of CB4. And while we do have patients coming from all over the country, actually, I will say we have patients coming from Pennsylvania, Florida, to come get their HIV care, every 3 months. The majority of the patients come from these zip codes, over 70% coming from the community, from all of you, and the people we serve as well. Next slide.
So, then that down. So, we are fortunate to work with community health centers of New York State. And they give us great feedback and information about all health centers across New York State. So 2.3 million people are being impacted in a way where they're actually being seen in federally qualified health centers. And that allows us to provide for the quality of care and service that we like to give to our patients. And with this information, it allows us to move forward and be able to identify the needs of the community, do needs assessments, continue to say that although there are high incomes in our areas, there are a significant amount of individuals who need services within our areas. Next slide. Next slide. All right. So these are the community wellness and community engagement activities that we engage in. Because we're more than just a health center, we educate and focus on the impact of wellness. And we work with our community leaders and most community-based organizations, faith-based organizations, not-for-profits, to help us collaborate with the things that we do and the services that we don't do, so that we can provide whole care for our patients. Next slide. Definitely, as you look at an iceberg, it's more than meets the eye. I think it's a really great analogy for us. People say healthcare and you think about what's on top of the water, but we're about everything underneath the water. So I'm gonna go through a couple of things that really kind of illuminate some of the other things that we do in conjunction with the things that we actually do that you think of when you think of a healthcare center. Next slide. So AmeriCorps is one of those things. So do you want to introduce what AmeriCorps does and the value add? Before Carla goes through this, I just want to say that this is our way of also giving back to the community. While it allows us to serve the community, it also allows us to employ the community. So Carla, if you can go through that.
Yeah, of course. The AmeriCorps program is a public health program we usually recruit recent graduates, but this is a US federal government granted program, but it's also funded by donors and other organizations that partner with the Community Healthcare Association of New York State to provide this program. This program, as you can see, we have a chart. We are the host site, the Federally Qualified Health Center. Ryan Chelsea Clinton provides day-to-day responsibility to AmeriCorps members who are in the program for 10, 11 months on a full-time basis. So this program provides opportunities for growth for new graduates who would like to get experience in public health, would like to also build a career. So this program provides them this guidance, support from supervisors. Then who oversees the program and has the responsibility to implement the guidance is the Community Healthcare Association of New York State. They provide the contracts for the AmeriCorps members and all the benefits for the program. But also who oversees this portfolio is the Commission on National and Community Services of New York State. They have like AmeriCorps and the services they provide, and they oversee these programs. And this finally is the AmeriCorps, which engages over 5 million Americans. So in their programs, it's a great program for members in the community, for recent graduates. We continuously recruit onboard members. We do have 15 AmeriCorps positions at Ryan Health overall, and they serve in all the 7 sites we have. They do different programming, coordination, they learn about public health, community engagement, and they are in the community working on different events, and all these great initiatives we have. So it's a great program.
And we have
that
4
we share.
vacancies.
We have 4 vacancies right now, 3 vacancies, because we just. Yes, 3 vacancies right now with the program, and it's still growing. It's 19 years with the AmeriCorps and being as a host site for the program. So it's still growing, and we see a great success from members. And we have also a great retention rate, 91%. So our members are really getting a lot from this program.
Next slide.
So, and the program has various benefits. Some of them include living allowances, educational awards, health insurance, MetroCard, unlimited MetroCard, travel reimbursement if they don't use unlimited MetroCard, educational loan forbearance, member training and professional development, and even childcare benefits. This is a 10, 11-month program, 1,700 hours. We recruit on an ongoing basis. Our program started in October 24 and is gonna end in August, September 2025, but we still continually encourage members in the community to apply if you are interested in public health. The eligibility is to be interested in public health and be available on a full-time basis, 31 to 40 hours per week.
Next slide.
Sorry, is there an age, I don't interrupt, is there an age
Limit?
that you're focusing on for this program?
No, there is, so if an individual is interested in applying to the program, we don't have age limits. We do have members who are recent graduates, but we also have members who are returning from their from the workforce, even like senior workforce. So if they like to apply to the program, serve in the community, this is a program for them.
Great, thank you.
Thank you, and they are heavily involved in a lot of our community events. We do a lot of community events in tandem with them. We do voter registration, we communicate with medical screenings and have individuals both at our organization and other organizations. We do book drives and giveaways, back to school supplies, vaccinations at other locations where we actually provide our nursing staff to go to the location, whether it be actual residential environment, and provide the vaccination so that we can get people well. We also have mobile unit visits, so we have a mammography unit that comes to our location, and we have 2 of them. So we have one mobile unit that takes patients with insurance, and we have a mobile unit that takes patients without insurance. So that we can cover the
So that's at
entire.
your site or that your mobile units go out?
So the mobile units, we have a few. So we have mobile units that go out and then go out to different events. And those mobile units allow us to screen patients and give them vaccinations. We also contract with Mount Sinai, and Italian American, which have mammogram units. And so those are really key because they bring that mammo unit to our location. They park right in front of our facility on 10th Avenue. And that allows our patients to go in an area where they're comfortable and they know how to get there, they can transport there. And so they know they can come right outside of our center and get their mammogram done. And so, you know, some, based on their, those are different organizations, so we have a subcontracted relationship. So some of them take insurances, so for those, we have to parse those patients that have insurance and assign them to go to that mammography unit. And for those who don't have insurance, we have to parse them to go to the unit that accepts the one without insurance. So that's a really important distinction. I'm glad that you asked that question. So we want to make it accessible for everyone. Next slide. So this is Health Center Week, in front of our health center. You get to see us actually out there, both the AmeriCorps members and our outreach staff and some of our day-to-day staff, along with our elected officials. We're all out there in the rain. So Shape Up NYC was helping, and on the left-hand picture, they come to our health center 3 times a week, Mondays, Wednesdays, and Fridays. And they give free classes at our health center. So whether you're a patient or not, you can come to our health center and work out. And get rid of that gym membership, come on in, and shameless plug. We also are giving food arrays, so that's fruits that we're giving away in the middle, and on the right, that's our picture with Brad, Siegel. Is that saying right?
Yes.
Okay, he's our congressman in our area, so we're excited to do this kind of events for the community, continue to work with other community health organizations, and they came out to share with us Community Health Center Week, but to share with the community, all of the services we do together. So we're a health center, but we community with other health centers. So working with Dress for Success, and they gave us some clothes to kind of fashion show model and show others that if they have job interviews and things of that nature, they can go and be styled. They can get these clothes. They have a new edict, so they're not taking donations. They actually gave clothes with all the tags on them. And that's what they're giving to patients. They're going out to, well, our patients, they're giving out to their clients, as well as having AI technology that helps them align people's skills so that they can help them gain employment. So those are the kinds of organizations we work and partner with. We also partner with the Immigration Project that allows us to help people to get documentation and legal counsel to apply for citizenship. So we're really excited about partnering with these organizations that help do more than just healthcare, but help in a holistic type of way. So next slide. Thank you. This is a continuum of our patient population's care team. Our care team consists of the top, which is all of our providers, from medical doctors to nurse practitioners. We have a wide array of providers to take care of our patients. We even have Mount Sinai residents that come in and train at our health center and work with us. As you go to our right, we have a cadre of our nursing staff that allows our patients to be able to get the best care that they can with a coordinated team. We have front desk staff that work together. As we mentioned before, we have subcontracted staff. So those mobile units we talked about that come in and help us. But we also work with Fountain House that does mental health services and assists us with that by coming into our facility and seeing our patients directly. And so all of these work together with the patient in the middle. And our goal is to make sure that we provide the highest quality of care for our patient, and doing so in a way that makes them a whole person. So their medical cares, their mental health cares, their dental cares, their primary care. We do all the services that we can for that patient. And when we don't do that service, we contract with someone who does that service. Next slide. Okay, next slide. So this is just to give you an idea of all of the services that we do. Sometimes you go to a doctor's office and they go, yeah, we don't do that here. We just do primary care, or we don't do dental here. So we don't do that there. We do everything. We do primary, we do pediatrics, we do women's health, we do gender affirming care, we do eye care, we do dental care, we do opioid addiction, HIV, AIDS prevention, sexual and reproductive health. We even do school-based health, and we do specialty care. So it's our job to do a more comprehensive job of making sure that people have what they need in a place that they're comfortable, a place that they know and trust. And so it's our goal, any chance we get, to provide more services for our patient population. So anytime we can find an additional service that's needed and we find that the community wants that service, we find a way to provide that new service. Next slide. So this is a really great example of sometimes the community education that we engage in. This is one of the things that we talk to our patients about is being able to get access to service. We talk about Judy, who's a cisgender woman. She's engaged with sexual activity with 2 different partners and has the patch that she uses for contraception. Judy does not use a barrier method contraception, such as a condom. Is she a candidate for PrEP? And PrEP is it stands for prophylactic, pre-exposure prophylaxis. So most of the times, individuals would think that men who sleep with men are the only people who are available to get PrEP, and that is actively not true. And so that's some of the work that we do, because it's really important for people to understand what the services are that are available, because if you ask somebody, do I need PrEP? If I don't know what it means, I could say no, but the answer could really be yes. And I think that's where our most impactful work is, really not being condescending, not being judgmental, but giving our community the tools that they need so that they can be safe, informed, but also so that we can provide people an option and that they're available to them. So many things were not available for the underserved, or so many things were left because of funding to those who have insurance. So it means a lot that we can provide quality care, that we can provide education, and we can do so in a way that gives everybody dignity. And so I'm really happy that one of the things that we do at Ryan Chelsea Clinton is bust myths all the time. Making sure that people know that they have a right to know things, give them the information and make them feel very solid in the new knowledge that they've acquired. And lots of times you hear them tell the stories over and over again, which is quite great for us to see that they're using and retaining the information. Next slide.
Before you go to the next slide, what is a cisgender woman?
Can you go back one slide?
Someone who identifies as a woman, who was born as a female. I'm a sister.
Gender identity.
As opposed to
No, that's not correct. So the gender identity is it's in alignment with what they were assigned at birth. Meaning, I was assigned at birth as a male. I identify as a male.
I'm sorry, you were born as.
I'm a cisgender male. I was assigned male at birth.
Okay,
I also identify as male currently. So my gender identity and my sex align with each other.
and that's called cisgender?
That's cisgender.
Yes.
Why don't you just call it a man or a woman?
Because a trans woman and a trans man are also male or female, but they may not, their gender assigned at birth is not aligned with their gender identification currently.
So that's a perfect example. Thank you for the question.
Mine, yeah.
So that's a perfect example of trying to make sure that our staff are very clear on how we communicate with our patients. We also have it in our electronic medical record, the pronoun that our patients would like to be called, he, she, they. It's really important to understand that, and if someone is gender fluid, to be clear about that as well, so that we can be respectful to our patient and that they can be receptive to the care. Because we want our care to be a care model where our patient comes together with us and engages in their care plan, as opposed to a provider who just tells you, this is what I want you to do. We want our patients to meet with our providers and create the plan together that patient will work to achieve, as opposed to someone told me to take these pills and I don't agree with it. And so I'm just not gonna take those pills because I really didn't agree with that. So our goal is to create relationship and dialogue in a respectful environment so that people become partners in their care. So I think that was excellent question.
May I ask a political question, if I may? To me, this seems very normal, but would this be like an abnormal kind of service, say, like in Florida or Texas, or does it make a difference?
Well, I think it's a great question because that's what federally qualified health centers do. That's how we step in the gap. If you go to a private doctor, you may get whatever that private doctor's viewpoint is. As a federally qualified health center, I am mandated, one, to identify everybody that comes in my health center and make sure that I give them a voice by having them select what is their race, gender, ethnicity, and sexual orientation. I do that because it allows me to get funding for them. because I say they are here, they are being counted. So they're not being counted in a way to be singled out, but they're being counted so that they won't be marginalized. So that their care and their needs and their service that they get can be specified for them. Especially in our, like in CB4, for instance, we look at the amount of money, when you look at the median income of the individuals that live here, and some individuals make so much that they pull the median income up pretty high. And when you look at CB4, you might see something like 38,000, 145,000 as the median income of an individual in CB4. But we have so many individuals that aren't even close to that and are at 150 to 200% below the poverty level. But because of those individuals who make so much more, they pull the median up, and then it appears to anybody looking from the outside, we don't need assistance, and that we don't serve this population that's underserved or underrepresented or underinsured, or as William mentioned, some people are coming from so far because of the dignity. Some people are coming so far because of the consideration. People are coming so far, like I went to, Washington DC, or I'm coming from Philly, or I'm coming from someplace, but I come back here also because of the anonymity. We provide HIPAA, which is a quality care where we don't share their information. We don't, everything is confidential. And so I get confidential service without judgment by people who care, by a high level of professionals. And I don't make a lot of money. That's incredible. Right, so I don't deserve less because I don't make a lot. I don't deserve less because I don't have insurance. And so that's kind of, I'm so glad you asked that question, because this is kind of what this is all based on. And so this becomes our material. We're used to these things because we live it, So I'm glad you asked that question, because it also reminds us to slow down a bit sometimes, that, these are things that we live, but we want to make sure everyone that's brought into the fold will continue to experience that. Next slide. I'm going to speed up because I don't want to. So, do you have to be uninsured to come to Ryan Chelsea Clinton? Absolutely not. You can have no insurance, you can have Medicaid, Medicare, you can have marketplace insurance, you can have employer insurance. The goal for us is to make sure that we see everyone, regardless of your ability to pay. We're gonna take care of you. Next slide. William talked about this a little while ago, but I think a graph is worth 1,000 words. So since 2015, we've continued to increase the amount of patients that we see per year. So what you see here are individualized visits of patients that we've seen. The only year that we didn't see more patients and we didn't keep the uptrend was COVID year, 2020. So nobody was seeing anyone, but we still saw a whole bunch of people. Like, that's pretty amazing, the amount of people that we saw. And that's because we were vaccinating people. We were on the front line, making sure that people got their vaccinations and people were kept safe. And so while people were home, Ryan Chelsea Clinton was working. And we're looking like we're poised to see 55,000, 56,000, 57,000. We're excited for the end of 2024. Because that means a lot. We are bursting at the seams, physically. Our physical plant is at capacity, and so we struggle on some days to find exam rooms to utilize to see patients. And anyone can attest, if they've worked there, they may have been thrown out of a room. So if the need was greater, if the next person was coming and they had a patient, then we have been asked nicely to displace from that room. Next slide.
Actually, can I ask a quick follow-up? I think earlier in the presentation, you gave a number about individual people who've been served as opposed to the number of visits.
Yeah.
Like, so one person might come in for several visits. Can you remind me what that number
I
is?
said 15,000
We
registered
have
patients.
approximately 15,000 registered patients.
And do you have to be registered in order to be seen?
Yes.
Okay, got it.
Yeah, unduplicated patients, and then those are the, like you said, those are the visits of those unduplicated.
Gotcha. Okay, thank you.
And so in our recent history, we've been doing a lot of vaccinations. Our COVID vaccinations from 21 to 22 was 14,429. We made sure that we looked at our COVID and flu vaccinations together. We did 6,387 vaccinations altogether, and we respectively 2,772 of those were COVID, and the residual 3,615 were flu. Monkeypox was a vaccination that we do as well. Very expensive vaccination. So that's a lot less. We did 633, and we struggle with that, getting the funds for that. So we do get some subsidy for some of those, but the rest of them we do pay ourselves. 476 active PrEPs were given out. We did 25 PEPs, which are emergency. Those PEPs are in case of rape after somebody's been exposed. That's that kind of emergency where someone has been exposed to HIV, where they would get the PEP. And our asylum seekers, we've seen actively to date over 9,000 asylum seekers. Again, once COVID was over and individuals started arriving, we are just a couple of blocks away from Port Authority, and so people were directed to Brian Chelsea Clinton to be seen.
So am I understanding the numbers correctly? You have 15,000 registered patients, and of those 9,000 are asylum seekers?
Those are additional. Those visits.
So of those 15,000 registered patients, how many are asylum seekers?
Those are two separate numbers. The
Two
15
separate
two
completely.
separate numbers.
Ah, okay,
15,000 existed, the 9,000 are
I see, okay.
independent. Those are the people who came in, and they may not come back additionally. So they may have come in, gotten vaccinated, been seen, and then we may not always see them again. So I think, you know, the point of registering people is one thing, but then consistent care is something else. Yeah. Next slide. So we do have a board of directors, like your board of directors. We're always looking for more board of directors. We're always looking for individuals who are from the community who can continue to steer the organization. And so we ask that you help us with that as well. Our board has to be members and individuals who actually come to the health center. Right now, we have 75% of our board are actively being seen. But again, always wanting individuals in the community to continue to thrive and drive the organization about what's going on in the area and the community. So it's really important for us to have that. Next slide. We have community advisory groups, a general community advisory group and a transgender community advisory group. Next slide. And that's really important for us as well, because we want to know the day-to-day experience of our members. Our community advisory group is 7 to 10 members. They meet 6 times a year. And we take feedback directly from their experiences. So not just one experience, but the sum total of their experiences, their general overview and feeling for the health centers. That's really important because it gives us a bird's eye view of what people are experiencing versus what we want them to experience. So both of the community advisory groups are run by our deputy director. And so he's able to get direct feedback and then put that into action in terms of discussions with staff, making changes with policies and procedures. One time we got some feedback about our electronic medical record directly or our patient portal, and we were able to get that information back so that we can make the changes to make individuals work daily approval and work of how they experience the health center better. Next slide. This is our state of the art. So we work really hard to make sure that our community health center gives our patients everything, if not anything better that they would receive from a premier institute. So on the right, you'll see our retina view machine. This is what we use to make sure that our patients get annual screenings, eye screenings, and that we really get a good view of what's going on in their eyes, and we make correct diagnoses. In the middle, you'll see a bunch of these rolling carts of computers, which we call cows, computers on wheels. And they allow scribes to go into the office with our providers, so our providers can give you eye-to-eye contact while the scribe is writing down everything that they say. On the left side, you see the manometer, which takes your blood pressure, and you'll also see a sexual health kit, which allows us to screen our patients real time and give them the results that day. So you don't walk away and wait for 2 weeks in agony. Do I have this infection? And you know, in 20 minutes, we'll know you have this infection. We're treating it. You're leaving with antibiotics for the right kind of thing. And to me, this is huge because this is the difference between being marginalized and being heard and seen. And so we're constantly making sure we're providing that high level of care, that we're not having antiquated equipment and machines and a broken down building and those kinds of things. It's just not acceptable for people who are underserved to get the lease. And so we work really hard to make sure that they don't. Next slide. We make sure that we bring diversity, equity, inclusion, and belonging to everything that we do. We put it in our strategic planning. We make it a part of our mission and vision, as part of our hiring practices, as part of our discussions. We let our patients know when we discuss different things, what we will be doing at our health centers to make sure that they're a good fit. So that we don't have these issues with people coming to our environment, whether they're providers, whether they're front desk, whether they're social workers, whether they're housekeepers. We want them to understand that these are the people we service and this is how we service them. And if you're gonna come along with us, then this is how you have to service our patients. Next slide. Go to lots of encounters, back to these events. This was AmeriCorps showing up at Trans-Latinx Wellness Fair and an event where over 50 LGBTQ plus clients were serviced and got gender affirming care information and how to register for our services that we have in both English and Spanish. Next slide. Again, we do our dance class, body weight circuit training, 3 days a week. We have some level of fitness class. We also have trauma toolkit, which is a group that we do at our health center that's available to all patients that allows them to get the tools to deal with the lifestyle of trauma. We have our mobile units that come out and do the breast cancer screenings. Then we have fireside mental health chats where we discuss for that month, whatever that health issue is, and people can come and have conversations about that. We did a tremendous amount of fireside chats last month where we talked about suicide prevention because that was last month's theme. And a lot of individuals had an opportunity to really talk about that in an open and honest way about what some signs are and some tools. So it was very helpful for our population to be able to get access to things, even when they're not actively enrolled in a mental health program, they can still be involved in those things. Next slide. Next slide. So we do a lot of training. As I mentioned before, we go to Community Health Center of New York State and National Association of Community Health Centers. That's our education. We go and we learn from other health centers. We learn best practices. We learn tools and tips and tricks. And we also send our staff to training. Next slide. We also on New York City Vax Finder, so if you need to find a vaccination, you would come up here and find this. Again, we are a federally qualified health center, which means I cannot turn you away. There is no one who comes to my door and gets turned away. So that's really important because also we have to have what we say. Sometimes the funds for purchasing these medications can get difficult because with patients who have insurance, we have to purchase the vaccinations first, and then the insurance company will reimburse us once we see the patients. So lots of things we have to have money for upfront, and then on the back end, we get reimbursed. Next slide. Some of our needs, as we mentioned, we are bursting at the seams. 35,000 square feet sounds great. We could use some space in the Chelsea Clinton neighborhood because our building is truly maxed out. My deputy director does an amazing job of identifying from day to day what rooms he has available, and he plays a nice game of Tetris with those rooms, who he can put where and how he can align, who will work well, who's working a half a day, and who, once they leave, who's gonna come in, and he does that with such grace and ease, but it is not easy, I assure you. So we're looking for more space. My dental waiting list is growing. And that's because, as you can imagine, a dental chair and all of the pneumatic tubes underneath the dental chair means I can't use that room for anything but dental. So that means I need more rooms for more dental chairs. And so that is a need that we have. This space is a real need for us, not a pie in the sky, not maybe a thought, but you know, it's a real need for us. We expanded over a year ago.
3 years ago.
3 years ago. So we expanded over 3 years ago. And we ran right through that space. That space is used to its capacity. And so we're thinking that we're not going to do those little expansions, we're gonna do a bigger expansion because we wanna be able to grow into the space. As well as have that for the next 5-6 years, as opposed to doing it 3 years and then we're maxed out. So any information about space in the neighborhood that would, you know, fall under the community space would be really helpful. I mean, support to let us know where we can provide that, we can find that type of space that's accessible and that will allow us to build wheelchair accessible space, and we will be grateful for that. We now use our virtual visits to help us with some of the space issues, but because of New York State's funding laws, our staff must be on site. The patient can be virtual, but my staff has to be on site. It would be great if the laws were relaxed, because then the individuals could actually be elsewhere, and that would help me with my space issue, but that is just not how things are working right now. So, right now, we're working on trying to get additional space for, the health center to grow. Next slide. We need a new retina view machine, so that's one of the things that we need, and we wanna work towards having that. That's, that high powered machine I showed you on the right, we've had that machine for about 24 years, and it's time. The machine is, breathing this last breath, and so now we need to get a new retina view machine. And that does a great deal for all patient types, regardless of what the patient's visits are, what they're there for, and regardless of whether they're gender affirming care, whether it's somebody for GYN. When we go through the prospect of getting our patient their annual wellness visit, they're gonna need access to that. We also have a 24-year-old chiller on the top of our roof that needs to be replaced. As with everything, if you have it long enough, it needs to be maintained. And so that chiller allows us to cool off the equipment that we have in our health center and make sure that things are running well. So we need to do that. We also could use a new sonogram machine. That would help us to continue some of the work we want to do, which is to add OB to our cadre of services, which is another reason why we want to expand our space. Because the maternal rates of death are increasing in New York all over again. So it's like 1995 all over again. We worked really hard to get the numbers in New York down, and they're back up again. And so we have fetal demises, and we have maternal demises. And so getting primary care for women's health for OB/GYN is really high on the ticket list this year. So us really kind of being able to have more space to provide that, have a sonogram, and start to provide that service in the way that we do, I think the community really could benefit from us doing that.
Any estimate on the sonogram machine pricing? Because you have estimates for your retina view and the roof.
65, yeah, about 60, 65. Priced it last year, so it might be more.
$65,000.
Yeah, 65.
Yeah.
What is 65?
Yeah, it feels like it. But it's fun. And then, so I wanted to talk about something that's interesting, again, staffing, we talked about, probably letting people know and being aware of AmeriCorps, but also our staff, like, it's a wonderful calling to work with our staff. We'd love to have more people from the community be a part of it, people to see themselves behind the counters and patient service representatives, and growing into medical assistants, people going back to school and growing into nurses. And so we would love to see that. Our competition now, it used to be just hospitals, but our competition now is places like Target and Starbucks, because they're offering people like, you know, school and those kinds of things. So we want to make sure that people know we offer fair wages, that we offer full medical and dental, and that we're a place where you can be well and work. That is a place where you can feel like you're doing something for the community and you're giving back. And a place that you can go to and feel well as an individual, where you'll be welcome through our inclusion in our process. Next slide. Advocacy is something we would definitely require, and it would be really helpful. The price of everything goes up, as you mentioned, 65,000. So we've watched the price of vaccinations go up. We've watched the pricing of what the hospitals are getting. You know, since COVID, the hospitals got a lot of infusion of money. Those federally qualified health centers did not. Federally qualified health centers were at the front line giving vaccinations and giving COVID vaccinations when no one else had them. And so people who were typically not using federally qualified health centers during COVID were getting their vaccinations from federally qualified health centers. And so just kind of, you know, being out there and being able to advocate for us in a way, anytime you hear of the opportunity to support us for rate reform, we really appreciate it. So the amount of money that we pay for our visits, we get paid for our visits, and the amount of money that it costs for us to provide those visits has a big gap in the divide. And so that's always helpful. Next slide. And we just kind of have an amalgamation of patients who really feel great about the care that we provide for them. We do patient satisfaction surveys to keep our finger on the pulse of what people feel. both positive and negative, so we can make changes and updates. But it feels really good when we're able to hear from patients that they got excellent care and that the attention that they receive from specific people at the front desk or from the security staff or from the doctor. It makes a difference that people feel that their inclusion and that their opportunities for a good environment and a good medical experience can happen every time they come to our center. And I love to be able to provide that back to the staff, because in hard times, it allows them to continue to go forward. Next slide. So once again, our mission and vision is to make sure that healthcare is a right and not a privilege. We do that with care for our patients through our commitment to our mission to make sure that everybody is taken care of, and then regardless of your ability to pay, we're gonna see you. And we collaborate with not only our team, but everybody in the community. We work with the police department, we work with the community board, we work with faith-based organizations, we work with everybody to give our patients the best opportunity and a quality experience of life within the Chelsea Planet environment. Thank you.
Thank you.
Any questions?
Now you can take the presentation down. So just to start, just to clarify, so you're a federally qualified health center. And funding that you normally receive comes from both the federal government, the state government, as well as the private sector in terms of donations, is that correct? But do you receive any city funding?
We do sometimes.
Yes, we've had city grants, yeah.
City grants, okay, the reason why I ask is because our part of the budget process is we're appealing to the city of New York. And one of the important things is identifying an agency which may be able to provide for some of your needs. So just to make sure that we understood clearly, your biggest need is for space, so that's a capital need. But that would require identifying space in the area, which is not something that it's easy for us to ask as a capital expense. It's more of just being a community partner and trying to help you find that. But
Lawrence, may I qualify, or,
yes, please.
So I'm trying to figure out if the need is both financial and spatial, or if you, I think we had a version of this conversation last year, where ultimately it was possible if the space was available, that Ryan Health would be able to afford the lease. They would simply, we'd have to find an appropriate space, which is less of a part of our budgetary process, but might be something that we would include in other letters, or mentions to our, elected officials.
Yes, for the capital perspective, yes. From the operating perspective, like when we talked about, help with the immunization, sometimes with monkeypox, we're able to get a certain amount of monkeypox that are provided by the government and the state. But then the additionals that we would need, we come out of pocket with. So sometimes those funds to help us supplement those, that would be helpful, those funds. So the capital fund would be things that we can provide, we would need help with identifying space. So you're exactly right on that. And then the other stuff, which is like our sonogram machine and help with our retina view, that kind of stuff is like dollar capital that could help us provide those kinds of services for our patients.
Thank you for clarifying. I do see, Betty, you have your hand up.
Yes, thank you for the very thorough presentation. Perhaps I missed it, but there's a crisis over fentanyl, and I was wondering if that is something you're dealing with directly.
Yes, actually, we do have a grant from the city, actually, for medicated assisted treatment. So we have a nurse as well as an AmeriCorps member and a patient navigator dedicated to helping folks on buprenorphine, I guess that word. So we have about 60 to 70 individuals who are part of our MAP program who come in once a week to get tested and who are on buprenorphine, and a nurse manager tracks them and follows them and supports the providers to help them stay off of opioids.
Thank you. Are you finding that your effort is effective?
Right. And part of that harm reduction is also providing fentanyl strips to help, identify. And we also supply Narcan kits to help folks who overdose and things like that, and educate not only the staff, but patients as well.
Kevin?
Sure. Thank you so much for the presentation, and to you and to the healthcare heroes and staff you have for the work that you do every day, taking care of the patient population you serve. So thank you. We've got a couple of questions, and it's all gonna end up with, how can we help you? So just see, where's this guy coming from? You know where it ends up. But also just trying to find the pigeonhole of the funding, so FQHC is different from an acute hospital, different from a regular city agency. I know you don't want to get into too much, but HRSA, 30 grants, you get some state money from the, I don't know if you do, value-based purchasing stuff. But on the city level, we won't get into that, I understand. On the city level, who would it come from? The city Department of Health? In your experience?
So we get usually get grants that from individuals or.
So we get from the city, we get, like I said, the MAP program comes from, the DOHMH. Actually, Assemblymember Roosevelt also helped with that, and so some state funding as well. We do get discretionary funds, so at the city level, from Councilmember Boxer's office has granted us some discretionary funds. We get from State Senator William Siegel, we just got $20,000 to help pay for about 15 Mpox vaccines, more than that, but.
So nothing that
It was
we
about
can say
100, they're about $250.
consistently, it's not like we're gonna get a consistent grant, it's us asking and then them seeing what discretionarily is available, so it's not something that we can depend and plan on.
Gotcha.
So we have to wait till they provide it.
But participatory budgeting is going on as we speak, so through council district, I think Botcher is 4. Three. But in addition to what was on the slides, like 65,000 for this, 30,000 for that. Is there any funding, presuming we could get it, that can be helpful for you for some issues that are facing the community, in addition to what you articulated quite well? Like dealing with unhoused folks, people who are maybe mental ill. Betty touched on what I'll call detox, behavioral health issues, social work, women's health, and lastly, more funding to the employees who actually do the service.
Yes, yes, and yes.
It's all yes, the employees that do the services are always a tricky one, because it goes back to what you said about value-based care. Where we wanna go to a value-based care model, because that allows us to take care of the patient as a whole. And make sure that we do these kind of care coordination and transition of care types of things. As you know, those are not billable services. So if you give me the money today and I'm able to hire the staff and provide that service, if it's not a line that I can count on going forward, because it's not a billable service, I can't sustain it. I'll wind up giving that person back up. So those are the kinds of things where you need funding, but it needs to be consistent and it needs to be renewable funding when you're talking about staffing.
But even at this side, what about like unhoused folks or behavioral health issues? If we can grab onto that funding, is there anything that we can throw in your direction, figuratively speaking?
Definitely for mental health.
So I just want to caution the language I'm using. We're not throwing anything, right? So as a community board, what we're doing is we're articulating what the needs are to the agencies and hope that they can respond within the city budget. So I just wanted to just correct that. So you already know we're not throwing dollars at you because we're not, yeah. So I just
But we
wanted
can
to,
advocate and add our voice to yours.
Absolutely.
So hopefully it's good for the patients that you serve.
Yeah.
Talking about finance.
Yeah, no problem about it. So, one of the ways that, as Serena mentioned in one of her slides is collaborating with community partners, right? And creating these partnerships, because we can't do it alone, right? And the organization that we work with, such as Fountain House, who we collaborate with and we're agreeing with them to help serve their clients. And they help and they provide services to our patients, right? So we work together in that way. Carla's fostered a great relationship with Midtown Community Court. They just received a grant for patient navigation and we were part of that. So we're gonna be already, coordinating on that, helping, they will refer patients to our MAP program, Betty, to what you were saying, to help with services like that for opioid assisted treatment, things like that. So always looking for how creating the sum greater than its parts, right? So that we work together and to create a whole, a well-rounded care for somebody.
But definitely Narcan kits, opioid, which will help us with the opioid crisis, and definitely kind of working with monkeypox vaccinations, which are extremely expensive, as Will mentioned, right? So those are some of the funds that quantitatively would help which won't necessarily have to be renewed, but they can give us a big bunch of things that we can service the members with now, real time.
Thank you.
Thank you.
So Roberta, what I'm hearing is that we do have some agencies that we can go to, DOH, and just general health, like for some of the vaccines instead of possible.
Yes.
Sorry, Katie?
Yeah, I had a couple different unrelated questions, and thanks for your presentation. So one actually is about the sonogram machine. Make a super strong argument about the crisis of maternal mortality right now. And I'm just wondering, like, where did the funding come from for your last sonogram machine? Was there? Do you know, or was it just sort of general funding?
No, we've never.
No,
Oh, you've
we're-
never
we're
had
starting
one.
it. We're starting.
We'd like to begin providing prenatal care.
Yeah, we're starting
Oh.
because we see that the need, you know, it's one of those things where you know that the hospitals are in the community, everybody's providing that care. But our niche of patients, are they getting the dignified quality care that they need? Are they getting that voice? Are they getting heard? And we know that if we provided that care, then we would be able to provide that voice and we would provide that relationship to the hospital and they would get the voice and care and the quality. So we wanna do OB because we know that our population trusts us. They bring their children to us, so we know if we were to create OB, they would come and we could provide a safe.
Okay, but so that's, it's a new service, but you feel like if you got the sonogram machine, then you feel like you'd be able to sort of staff it with
And
OB
start.
care and stuff, yeah.
Yeah, cause that's gonna be a real pinnacle piece.
Yeah.
Right, just really being able to identify what's going on.
Yeah.
And start them off in terms of really assessing where they are, how many weeks pregnant they are.
Yeah.
Starting that whole process, getting prenatal vitamins, getting the diet and our nutritionist that's on site, all of those kinds of things together.
And for our population, you know, currently we would have to refer either, you know, we would have to refer to Mount Sinai, right? And if they're not commercially insured, they're not really taking Medicaid patients.
So what about your center?
We
Your
we
women's
refer them
health center
up to our
in
Upper
town?
West Side Women and Children's Center, but that's
That's not
District 7.
convenient for
Right.
Right, that's not convenient for us. It's not convenient for them, you know, we're glad to, you know, to collaborate with them, but, you know. We have a hard time sending patients up to Mount Sinai West for referrals, so. You know, if we could do more, you know, and as a community health center, we have a lot more services available in-house, like GI, urology, dermatology, podiatry, that a typical of UHC offers, so. You know, we're special in that way, unique, and, you know, I think adding will would really meet the needs, right, and that's what we've been doing, is really trying to identify community needs and meet them.
But I was wondering, can you give us a sense of like? I know this might be hard, but like sort of percentage wise, like, what are the most in-demand services you provide? Is it like 30% mental health, 30% HIV? I don't know, just I'm making up numbers here, but do you have a sense?
So we currently, our biggest demand is actually for the services we don't provide, like so actually dental is a good example. Right now, to get a dental appointment, if you're a new patient, you're probably gonna wait till 2025. You know, and we have 2 full-time dentists, 4 operatories, and they're not being used to the full capacity because they're also doing dental cleaning, right? We don't have room to add, we can add 2 hygienists and see so many more patients, but we just don't have the room, right? Or pediatrics, right? We've doubled our availability for family medicine and pediatrics. And it's still 2 months now because we fill, you know, because of.
You mean wait
the
time,
To wait time, to wait time, right? So on average, to see a provider is about 15, 16 days, but, you know, depending on, you know, if you, women's health, actually, there's a lot of availability. You can see our G1 tomorrow. Or actually not tomorrow, it's off tomorrow, but Tuesday. But, to see, you know, we went from, you know, before the new New Yorkers came in 2022 to now, we 300% increase in pediatric patients, right? And that just speaks to another reason, right? This is a young population, a population that is growing, right? And
That was one of my questions too, is like a percentage wise, is it, you know, are like, I don't know, is there, what percentage is like under the age of 15?
Actually, it's very interesting, because I just did this survey, I think I did the census, like, if you give me one second,
Yeah, sure.
more.
Precise numbers,
Precise numbers, so patients in 2024 who've had at least one visit under the age of 18 is 3,606. Between the ages of 18 to 64 is 10,566, and 65 and older is 2,275.
So you actually have had more younger patients than senior
Yes,
patients.
and that, and
Fun.
probably if you asked us this question 5 years ago, it would be the reverse, right? Because of availability, because of the population, right? Like we live among, Norks, right? They have Plaza, forget the name of the Penn South, right? Like all, but now with the influx, and we try to be, we want to be as agile as possible to meet the needs of what's in front of us. So we go out to schools, right? Carla works very hard to go out and fosters relationships with the community. We've gone to PS 111 and we've immunized students because all of a sudden the Department of Education has said, you can't come back to school until you're immunized, right? And we've gone in and immunized, 100 kids in 3 days, right, with our mobile medical unit, right? So we do, we do programming like that. So,
Oh, so, okay,
so specialties, like we would love to have, a cardiologist and not refer out. But we don't have space to.
so I know, a lot of schools, identify students maybe who could benefit greatly from some mental health care. And I'm wondering, presumably you provide that, but is there a pretty long wait for that too?
Yeah, 3 to 4 weeks to get it.
Actually, that's not bad. I mean, I've heard people say that, they've been told that it would be 6 months after me, not with you guys, but
Within
rather.
6 months, but I think if you're currently in care, we can get you in within 3 to 4 weeks. If you're a new person, maybe it'd be 6 to 8. Leaves a little bit longer for a new person who hasn't been seen at all. But I think the need is so great right now.
And so we started also, groups for folks who are on wait lists, so they come in and the DBT groups.
Trauma toolkit?
Huh?
Trauma toolkit?
Just
Trauma.
support
Groups, yes, that are social workers, and our therapists, facilitate. Once a week, we have a diabetes group, so we try to engage the community outside of the exam room. With the classes that Serena was talking about, and with the events that Carla facilitates.
Well, I just had one last question, and this might just be a crazy idea, and I don't know if it's really budget related at all, but. Like, you talked about the need for space, and one of the things we see is that how much empty space there is in some of the, how much empty space there is, exactly.
We were just thinking that's 6 dental operatories.
Yeah, we're not.
We really like, okay. Right.
Yeah, exactly, but I guess I was just wondering, have you spoken with any of our, I don't know, local electeds or others sort of about there are always people trying to think how do we make better use of our empty space for our communities, and has that conversation been happening?
Yeah, we actually just started having that conversation again, with clarity about, again, what we need in terms of the space, how, the size that we're needing and the location. I think the other piece that we're looking at is the gentrification of the areas and really being very clear. We need to stay in a place that is going to remain an area where people who are underserved can get to and where they're represented. We cannot afford to put ourselves in a place that's gentrified, because then we will ostracize the community that we service. So that's our niche as well. Making sure that we remain in a place where we're accessible to the community that is underserved and that they can get to us.
Yeah, so don't look at the space right here, because we're in the middle of Hudson Yards.
Yeah.
So I did want to follow up on a number of budget requests that we put forward in our statement of district needs last year, in part because of a similar conversation that we had last year. So I'm just gonna flag all of the different requests and we can kind of see where we are. I think last year we did make the request for we put in the statement a ultrasound machine, but analogous. I think everything that we understand there makes sense. Maria we wanted to clarify, it's 65,000 for the machine.
65,000.
Yes.
Was your estimate on a sonogram?
Yeah. Just wanted to confirm, and so that need is still there. It seems like you have confirmed the way that it was explained to us, it was being driven by the new New Yorker population and that, you know, this is a way to respond to the folks who have arrived and who are seeking services. And has that changed year over year? Just because I know that the individuals coming into New York City, that rate has certainly slowed, but has the population stayed in the area or continued to access services at the same rate?
Yeah, we're still seeing that. I mean, it's impacted us from a different perspective than that. Like even our translation services have like tripled because we have a whole bunch of people that speak Wolof. Which is a language that prior to them coming, it wasn't even on our radar to use that on our translators. So we've always had translators in the health centers and we, you know, Spanish, English, and occasional Portuguese and occasional Russian and occasional, you know, those like different languages, but Wolof came in. As a North African dialect?
West
African dialect. Northwest African dialect, and it's taken it by storm, and so the wait time for us to get someone on the line who can speak that language, and then that whole cost has exploded for us. So.
Can I just, I think I brought this up the last time I was here, in March of 2022, our bill for interpretive services was $3,000. I think we signed a check yesterday for $17,000.
And I assume you're using like a third party
Yes.
translation.
Yes. Right,
And you know, you do that by time, so if it takes some
Yeah.
time to find someone and then get on the line and then the time that they translate back and forth, so. And they're coming because we get translators, right? So now they can be understood, they can get their services met, so of course they're gonna keep coming back because we don't speak their language, but we speak their language.
Right.
So.
And that follows very well from the point that we made last year, but to hear specifically those numbers to maybe give it a little bit of additional color is very helpful. I also wanted to ask, we did have the space issue last year, and we would probably flag that again if there is, you know, agency space that can be dedicated for this purpose, perhaps that would make sense, but we would also highlight that the need is spatial, not specifically to lease real estate. Another place that we had a funding ask from last year was to increase funding for STIs, HIV/AIDS, and family planning resources, and I did want to ask if we've received, and this was an ask of the Department of Health, if there, the city's Department of Health, DOH&H, if there was any additional funding that you received through that, or if that is a continued ask. I think your point is like, we'd love more money to treat more people, but I don't know if there's any greater color to add there.
So we just received, we applied for a bunch of grants and we received a grant from the AIDS Institute for $200,000 to help with PrEP. And HIV prevention, so it's gonna definitely help us in the implementation stages right now, so.
Especially that piece that I talked about with getting more cisgender women involved, you know, and having them actively take PrEP and understand that PrEP is for them as well. So that education piece as well as providing the extra services can be a huge lift for us this year, and so we're really happy to get those funds because we're gonna need to get the word out.
And does that funding automatically renew, or is this something where you need requesting?
It's 5 years, so
Okay,
it's $1 million over the next 5
So we
years.
gotta stretch that over.
And
So it's not a specific ask that we're renewing in this budgetary.
no, we haven't gotten the money yet, but
We would just say
But we
we're
would just
supportive
give them
that you
the-
receive it, but
we were awarded the grant and it's gonna start. I hope not November 1st, maybe January 1st. Yeah, so we would have to reapply in 5 years. And our project officer will continue to evaluate us and look at our progress and make sure we meet the deliverables. You know, so it's also getting, testing out in the community, educating and referring individuals to, you know, men of color actually, to be exact. So.
That is really helpful. I think that those were the items that we mentioned last year. If there are, I think I haven't alluded to this, but if there are things that you would like
to see, or you think that it would be helpful for this board to support. In terms of asks to city agencies specifically, you know, please do let us know, and obviously, I can't guarantee that the rest of the committee will be, but I think everyone's very grateful and supportive of the services that you and your staff provide, so we can be helpful.
One last question, because I do know there was an ask, the mobile unit, you had come specifically to this committee,
Yes.
and was that funded?
That was, we have not had a decision on that funding, so.
Okay, so,
That was the New York State Transformation Grant that we applied for. Everybody was expecting to hear back from New York State Transformation Grant. September or October was supposed to be the answer, but. we didn't get that.
You know, wait and see.
I know, but September,
Oh,
October is
September.
now when they're supposed to have this conversation.
okay, and that was a state, right, okay, that's good.
New York State Transformation.
And any other questions? Okay, so for what I'm hearing is that you clearly have some needs. A lot of the needs are the same needs as you identified as last year. What I'd like to know from the committee is, in this particular case, for those of you who aren't involved in the budget process, we do advocate for budgetary needs, but they are based on the board having taken a position. So it's not as if tomorrow I have a great idea and I say, hey, we should go ahead and put that as a budget need. We clearly have a community partner here who's identified some of their needs, but even though these are the same or similar to last year, it's important that we memorialize that if we're going to put that in our budget ask. So, asking of the committee, does anyone have a motion or recommendation on how we can memorialize the requests? Because I can't do it as I am acting on behalf of the co-chair. Take a moment. Yes, Robert.
I move to write a letter as the committee, both thanking Brian for the presentation and the information, indicating the gratitude for the offering of services and memorializing the presentation that was provided here. And also supporting the various funding requests. And so I'm thinking specifically the ultrasound, the space. We may mention the mobile unit, though that may not actually come into the budget task force piece, and we will, the translation services, and then we will also mention
Roof chiller and the retina view machine.
yes,
And the phone number.
yes, roof chiller, retina view machine, the sonogram, and then also we can mention update on the private rent.
So we have a motion. Do I have a second?
That's right.
Okay, all those in favor? Anyone opposed? One present not eligible? That would be me. Okay. All right, so,
Oh, wait, what about online?
no, I did raise your hand.
Oh,
Yeah, I caught that corner of my eye here, see. So thank you very much again for always being present, because you are one of the few partners that you show up to almost all of our meetings. You make sure you advocate for the needs of the broader community, but you also are keeping us informed of what you do. So thank you.
Thank you.
I guess, I don't know, I think that if we're going to move on to the budgetary items, if Melanie is still on, if we could, just have the expense and, with the capital budget spreadsheet, it's.
Thank you, Carla.
It's easy to pull those.
Okay, give me just 1 second so I can pull it up.
We are good on time, we will do this efficiently.
yes. Thank you guys for coming. And, did everyone here get a chance? Everyone's seen the email I sent out more than once, right? With the main request that we had. Kate, you saw my email too? You saw my email with the request items, and I think I asked everyone to like have an idea of the top 3 things. Top 3 or 4 things. Okay. So
To that end, can I ask a question
No.
about that?
Yeah, I mean, yeah.
What do you mean, or what is meant by when the DOH, MH made a request for the last year for a Ryan clinic, and the agency agrees, but different funding source? What does that mean exactly?
Do you have it?
Yeah, so, I mean, I think that this is, I don't know like what specifically, but I mean,
It's under the expense items number 2, your expense items.
yeah, so.
What does that mean? Agency agrees, but different funding source.
Yeah, so with, I mean, I just, this one, I am reading a little bit between the lines, but it may be that despite the fact that DOH is the relevant agency funding the work, they might not actually want it funding the translation services, or they think it would be more appropriate for a different agency to fund those translation services. This is something I can follow up with Jesse on. I think we want to continue to ask for that money. But if the agency or the relevant agency should change, we can follow up on that and see if that would be more appropriate.
So whenever we see that the agency agrees, but different funding source, that means we need to look for a different agency to possibly fund that.
I mean, we could always, go back to the agency and we think you should fund this, but yes, I do think that it would make more sense to try and find the agency that most typically or most appropriately funds things.
Yeah, and Jesse would probably have guidance. I mean, one of the important things is, we make the asks, we identify the agencies we're looking for, but there's also signaling in the budget process, and the signaling goes to electeds. As you heard, a good amount of the funding that they get is from discretionary from electeds, both on the city level and the state level. And so that's important if we're already identifying not only in the narrative, but in the very specific ask. For a lot of electeds, particularly in election years, if it's an easy ask, like, for example, it's just a $35,000 ask, they can very easily carve that out and say, hey, this is what I provided for the community. And we do see that, and particularly if there are issues surrounding that ask that are hot buttons politically. So it's also about just identifying the need, even if we don't have exactly the right agency sometimes.
I'm sorry. Which document was it you wanted me to pull up again?
If we could start, I will start with the capital, we'll do both the capital and the expense, and specifically the housing, health and human services tab.
Okay.
Thanks, Sally. Thank you to whoever brought the goldfish.
Yeah, I was gonna say, where are the goldfish this time?
So here's a napkin first. Oh, wow.
I brought all the facts.
Oh, you brought us that, so thank you.
Yeah, yeah, we're in.
Thank you.
Thank you.
Goldfish are healthy.
I think so. This is great though.
It's finished.
Omega-3s are so great, so versatile. Beautiful. Thank you.
I was about to ask if we had
Roberta,
So-
is this good?
This is, I assume, committee, can you see the relevant? This is also accessible in the Dropbox if you have a phone or computer and would prefer to look at it that way. Right now, we are going to look at the capital. Yeah, I think we're good, Nelly. Thank you very much.
Okay.
And so we have, on the capital items, 8 items. I'm happy to kind of run through the various items very quickly, and then I think we can start from a place of, we have this existing order. Do we want to change the order? Number 1. And number 2, would we like to add any additional capital requests based on letters that have happened from throughout the year, or other priorities that have been discussed by the committee? So I'm just gonna roll through them. The first one here is more housing for special needs households. And this is a capital subsidy for Hartley House. I believe this has been an ongoing request for very many years, continues to be one of our top here. Our number 2 is capital subsidy for, I guess preservation for other affordable housing. So we have, development at 560 West 52nd Street, 464 West 25th Street, and 500 West 52nd Street. And we've had this one on here for a couple of years. This sort of reflects the board's ongoing position. You know, we want more affordable housing, we fund this, you know, that is how we get people out of shelter or off of the streets. That's sort of the justification of how we have kept that on there. Last year, we added this request, which was provide funding to Ryan and Chelsea for an ultrasound for prenatal. And, you know, we got the response that it needed further study, but it seems like something we would want to keep based on what Ryan has shared. The next one that we have here are for elevators at Harborview Terrace, which is, you know, this is a very significant, you know, livability issue for the residents of Harborview Terrace. And so I think we have also kept this one on here for a while. There has not been an identified source of funding otherwise. And so given that the issue itself has not improved as far as we have been able to tell, like, you know, I think it's appropriate to continue keep it on there. We have another Harborview Terrace request, which is for roof repair, boiler upgrade, new building entrance, emergency exit doors, and retiling of building common areas. My understanding is that need continues. We have another capital request from Ryan, which is for the additional space. I think that we can, you know, we can have a conversation if we want it on here specifically, or if we want to take it out and just keep it in the letter, because it's not necessarily a funding need. But it is certainly a need. There is the continued support for the slaughterhouse site, which was a 100% affordable site where that was, I believe, fully funded, I think, last year.
Yeah, I think that.
And so we have continued support. We have another continued support, which is Harborview Terrace for HPD development there. And I don't think that we have specific updates on either of the continued support items, but I would, you know, I think that I would just propose that we leave any of those items that are there, and then we can kind of discuss any of the items here if we think they should move or anything should be added.
So I have a question, sorry. Katie, you put your hand up and I didn't get it. Or you said chewing.
Well, I was gonna say, I would propose, or just put it out there for discussion, actually moving up the sonogram machine up to our number one.
You know, my comment to that just is how budget works. These are all going to different agencies, so it doesn't matter for those top ones, which one it's in. And I think that the only reason why I would leave it in the order is because our primary concerns have always been housing and also the protections for affordability for seniors and those with disabilities, and those are a little higher up, and it's consistent with our narrative. And I think that that's helpful, but in terms of whether or not it gets attention, it's still gonna get attention because it will be the number one point of that agency.
And last year it was number 3 on the overall capital requests as well. So in our narrative, hopefully it also shows up pretty high.
And that's, I mean, it's not to belittle, it's just, I just think that keeping with the actual narrative that we will have housing and we will have social services probably as our top overall, that we stay consistent in the line. But what I wanted to ask was, Maria, we've had other folks come to us over the last year with some requests. Do we happen to have a breakdown for this committee of some of the requests that have come to us? Because this is based off of what we talked about last year.
I don't recall what has come before us this year with requests right now, and I don't have anything documented.
Okay.
Yeah, I have a spreadsheet. I don't think that we have any new ones,
Okay.
but
I can.
No, that's fine. I just wanted to make sure because again, I we had so many people come to us and present and
I mean, I would say it's possible, but I can't recall anything and I don't have it.
because we've had a few of the shelter providers that have come to us that talked about their method of operation, how they would work, and I just thought in some of those conversations, particularly the women's one that's right on Dyer, on the corner of Dyer and Faith, I thought that there were some asks that they had and that we might have memorialized in the overall letter, but our purpose of those letters were about their method of operation and what we were asking of them, so wasn't the focus. Kevin? No, I'm not in charge of this part. We're pretty
No,
good.
I appreciate it, because I have the letters up, so I will take a second look. But
From a suggestion. I don't think we came to a meeting, but we went to them as a walkthrough. Is there anything we can do for capital expense for the drop-in center that's opening up on 9th and 15th?
I was just thinking that, Kevin. Yeah,
Okay, you know,
well. I mean, I think, you know, we all identified like one of the potential. What we see as a very foreseeable problem. Is that they only have one washing machine. And their capacity is 75 people, and the machine, they have 2 dryers, 1 washing machine. And that machine is supposed to, is to be available to anybody who comes in and who wants to wash their clothes. But it's also the one and only machine that will be available to wash the towels of people who are showering and stuff. So,
But if I recall correctly, that was that way because of ADA rules.
yeah, in that particular room, she said, yeah, they, you know, they couldn't fit another one in there.
They had like I don't remember if it was the architect or who it was that they're working with, configure it in very different ways to try to have that.
Yeah,
That's not something that would be in our budget. That we would be requesting. Unless you're talking about purchase, what was your thought?
So,
If you could make it a little speedy so we can get out by.
Get to it.
yeah, okay, so my thought is frankly, like.
But
they
we're
had-
doing good on time, right?
Yeah.
Yeah.
My thought is actually to say, you know, lovely to have a dozen showers or however many showers they have, but actually to use one of those showers. And, you know, water hookups for, you know, or to offer them, to ask for money for another washing machine for them, because. But anyway, but that is something we would have to like. Check with them to see if they need it, we'd have to have a letter about blah, 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 but that was in response to what you said, is that, you know, they clearly are coming online, we know that they're gonna have. We wanna be supportive,
and I've tried to help spread the word in the community about it, some of the food pantries I do, the church I go to, they're waiting for it to open up. There's a need for it, right?
Yeah.
And the other thing is, has Mount Sinai, is Mount Sinai West in the jurisdiction?
Yeah, we actually meet there.
That's correct. Rarely. Have they come before seeking funding for anything?
In the past, not this past year. They've been, well, last time I think
I
they
don't
come
remember
to
that.
talk about funding was, but I mean, the last time they came to talk about funding was probably like.
They're just as a general, this is a general kind of thing. And this is well intentioned as a health, the housing, health and human services, the health component of it. This is a wish that something.
The last time they came, we were on 44th Street and we were talking about the closures that were happening.
Right, that's the last time budget wise, it was probably like 5 years.
Yeah, I don't even remember it on the
I
budget.
guess there's no conduit within the confines of like having had done a letter about it, and a tangible budget ask of like. What's in the district community needs of. Trying to give, whether it's to Ryan Nina, drop-in center on Mount Sinai West. Some funding, whether it's for behavioral health or social work is. Desperately needed, or as they said, detox. But there's no target area, so we can constructively. Concentrate that.
yeah, I mean, you raise a good point, that what we hear from the community all the time is that they have real concerns. About the number of people who are out on the streets who clearly have mental health or detox needs. So we hear that there's sort of, from their viewpoint, a safety concern. But I think what we recognize.
But also servicing.
But yeah, but exactly, but so. Which could be addressed by services, but maybe what we need to do then is to think about who we could invite in to our committee meetings to come speak to that, so that then we can help identify how we could advocate for those things that then would actually be meeting the concerns that the community members have raised to us. You know what I
Yes.
mean?
Yeah, so
Does that make sense?
Ryan Center talked about, they partner with Midtown Community Court that has outreach, et cetera, and they actually they previously had some funding from the district attorney's office. Now there's an organization called Bridges, which has funding from a grant from the district attorney's office to do specific outreach and offer services for street homeless. I do think that they're aware of the community board. It doesn't mean that we can't still invite them in, but they do know that that's an avenue for them to advocate to, and since they haven't come to us, it may be that their funding streams are coming from somewhere and they're not expecting them to come from agencies. That's just my thought, because they know who we are, they've engaged.
And I have had a one-on-one with the director of that Bridges.
Oh, Bridges, yeah.
For this area, so.
Yeah.
And the last thing, and I'll get off it for the sake of time.
Thank you.
There's some kind of program being put out for now with the acronym PATH, but I think it means, so something's on the train with a police officer and a nurse or a psych. And I think the council member in this district, my words, not anybody else's, is looking for social workers to be available in the precinct level. So whatever way, if at all possible, this committee and this board can be helpful in terms of getting those vitally needed services, whether it's unhoused folks, people with detox issues, people with psych issues, behavioral health issues. If there's a way, I'd like to see for us to try to explore that. That's the only push for it. Yeah.
So here's a recommendation, because we don't have the specific asks, and maybe we can discuss this Monday at Budget Task Force. Is that in our narrative, we identify that these are some needs, and we recognize that there are organizations that are doing this type of work. And we generally advocate for support for the needs. And then we're not singling out because we don't have an organization specifically, but at least we're identifying it. What are your thoughts on that, Roberta?
So the one thing, and I'm pretty sure what we're talking about here is a pilot that the city has put forward in certain communities, not community District 4, where there have been social workers who have been sort of embedded precinct level. And I think that the council members' request has been recently, over the past few months. How do we expand this here? I think we have a very well documented bit of literature sort of justifying this, but not making that very specific ask.
I'll just add to the conversation that Jessica Chait and I actually, it came up about, I think specifically what you're talking about is the Be Heard program. That's what it's called, and that Eric Botcher is supporting. He's talked about Be Heard. And so Jessica asked me, well, what do we think about us discussing it? And I said, well, actually, CB4 did a mental health forum in 2023. That was our second one. And we did that one, and I had to look at my email to remember. But we did that one with CB2 and CB5 with the support of 1, 3, and 6. Okay. And one, Be Heard, really the forum was about short-term solutions for mental health. And mental health issues that we see in the community versus long-term. We didn't really hone in on or discuss a lot of long-term solutions. We talked about short-term. Be Heard would be one of the short-term ones. We actually wrote a letter about the forum, and that was included in the letter, and we actually got a response from the city. And I did tell Jessica that I think the budget request item asking for expanded street outreach is the closest thing we have to the request of Be Heard, but there's nothing specific about Be Heard. And I said, I think it's fine if we add it, if we really think it'll help the cause.
Well, what I was suggesting wasn't the specific program. What I was saying is that in our narrative, we can say that this is a need, it continues to be a need, and mention there are potential pilot programs and organizations that are working towards these solutions. And we as a community, because it's a great need, are supportive of finding areas in the budget to support the organizations that are doing the good work.
I agree with that. And we can wrap that into expense, which I apologize, we have not, we will hit.
Right. So should we bring up expense now?
Yeah.
Well,
Uh,
before we
if
move on,
there's
before we
anything
move on
else.
to expense, can we talk about capital a little bit more? A couple of concerns I have. One was your comment, Dolores, that this has been an ongoing request for years and years and years. And then column number 5 or number 6 says, what did it say? It said something, this is for further study.
Yeah.
What does that mean? Does that mean we're ever gonna get that done? Is this going to be done, or is this just a matter of them? Dismissing us? Are we wasting our time making that request?
Yeah.
Should we be making new requests, something that can actually get funded? I'd like a little bit more clarity about this.
So would we. And I say it smugly like that because this is how agencies will respond. If there is no budget specifically for these things, a lot of times they'll, instead of digging into it deep, they'll say there's further study. That's a common response that we hear across all of the budgetary acts. But then you also will get ones where they'll say, not, this is not our agency, our responsibility.
Right, like the one for DOMH.
So again, it's a standard response.
But then we go back with our standard ask. So when does something get done?
Yeah.
We've
You're
had
asking
things,
about effective advocacy.
yeah, we've had
Okay,
things
just
like
because we
this
always
for
ask for it.
15 years, and again, sometimes it's a hot issue for an elected, and suddenly it gets done like that. But if we don't have the ask, if we haven't demonstrated that it's still something that's important, it doesn't have the opportunity of getting resolved.
But if it's one of our priorities, it needs to remain there for years and years and years. It's showing that we value this is important to us, and it's documented. That's really like,
Moving the tow pound is a great example.
or even the Parks and Recs building on 25th Street. That was something that, my understanding, it was on the budget request for years.
The
I don't know if it was-
library down on the Mulberry Library, I mean, like, these are things that have been on forever because it wasn't something that they could put in the budget at the time, but it's still a need and we're identifying it.
Because to some degree, the budget is a statement of principles, that which we believe.
And
Well,
so
I believe it's called the modern drip method, right? That if we just keep dripping in the same place year after year, then finally something will happen.
I mean, when the tax base goes up, there are years where we see a lot of things get funded, and I think 2 years ago, we had a lot of resolved requests. It just happened, and that's great.
There's another thing I don't like about the budget, that there's no money attached to it.
No.
There's no specifics here. Whereas your suggestion, sonogram machine for $35,000, that's clear.
Yeah. Yeah.
Let's put it in there and let's see if we can
It
get
looks
that.
doable, achievable, right?
Yeah,
Let's just
yeah.
throw it in as number 1 and see what happens, but yeah, I understand that, like,
So, just that.
it's not the process.
We have been specific at times. I think the problem with putting in a monetary value is that's an estimate now. And like he said, he thinks it's 65,000, but that was when they priced it last year.
Right.
It could now be 100,000. So that.
Or no model by the time we get to it. Same thing with the elevators in the public.
Yeah.
I mean, it's not until something happens, somebody gets hurt, then it's gonna receive the attention.
Okay, going to expense.
Yeah, so I will close out capital and go to expense.
So are we saying that like we're leaving it as is?
I guess that's a great question.
Well, you confirmed that we had no additional requests.
So the one additional that if we're memorializing, that I would propose to sort of wrap up into the ultrasound request would be the other capital request from Ryan. If we want to separate those two out and put the roof and the eye examination machine, if we'd like to put those elsewhere or lower down on the list, we can. I don't know if the committee has any thoughts on.
I think I missed the cool roof part of the conversation. I mean, I
It
support
was just one of they said that the roof cooling unit, which keeps their equipment at a temperature where it won't burn out, is old and the price is 65,000 to repair.
I'm supporting the team plans to do so at that point, it's fine, like.
I guess I would just say, I would maybe add the eye machine and the sonogram machine together. And then the roof separately, because like lumping in a huge, super expensive roof to the machines is gonna mean the machines don't get done right away.
That's
You know what I
fair.
mean? So like maybe two separate.
Good point. In terms of your question about the response of, does the committee continue to have the order? I think what makes sense is for at budget task force is to ask the question, to say it was raised by Katie, whether or not those orders should switch. And I think once we get the survey back, because the survey closes
That Wednesday,
on Wednesday.
right.
By the way, if you can, send it out to your listserv. If you want to as a BCC, if people in the community, just send that out so they can reply. But that, I think that would be helpful to inform what order makes sense.
All right, I mean, how would anybody in the community know that Ryan really needs a sonogram?
No, that's not what I'm, no. The survey is asking what are the most important needs of the community. It's a very short survey and it's
Right.
asking what our community needs. So if we happen to have more folks that are identifying that the needs are around medical services as opposed to housing, right? Then maybe we should move those requests up in for our committee list higher. But if it still continues to be needs for social services, needs for affordable housing, then the order that we have it in currently. No,
This was a good question. Am I correct that I mean that now has 4 adults
This would put them at,
cumulatively?
that would put them at I guess a fifth, if we're putting the chiller as a fifth.
So I defer to your experience, whether on this document, it should like skip or should be all together. Does it make any strategic difference? Will they say 5 no's to Ryanita if it's all together, or does they say 5 no's to Ryanita if it's spread out?
It is there, I don't think that there's a particular strategy beyond, trying to prioritize in the way that we would, prioritize our, these in terms of importance to the community based on the state of the district needs in our previous letters. I think Dolores indicated this, but to the extent that you have Department of Health and Mental Hygiene asks, those are all going to get matched together and sent to the appropriate agency or OM unit, probably both of them. And so in that way, it sort of doesn't matter, but I think it's important to memorialize them. Are there any other, I guess, questions or flags? I guess I have one other question, which is, should we keep the space ask here? Because they're not necessarily asking for funding, but agencies may be able to provide space.
I think it's important, certainly because that's what they said their biggest need is the bursting of the seams. And yeah.
Okay, and I think comfortable keeping that there. Any other additional, any other movement of any of the items?
Didn't we say that some of them are basically funded? So
There are there's an expense, so we'll get.
The last 2 HRA are already funded.
Yeah, those are the continuing support,
Yes.
which that section is put on to, 1 is to memorialize that it was asked. 2, also as a thank you, but 3, just to let people know we care, right? So our list has a lot of things that either are already funded and we're just demonstrating like a continuity almost, so to speak, like because we asked for it, we got it, okay.
That's valuable
it
real
is-
estate, don't you? We put new things in there.
Well, in
No.
these instances, I guess the other thing that is important is they're funded, but then these are ongoing projects that have not been completed. And we want to demonstrate that we would like the funding to continue to be supplied for these things, even though it's been allocated and that we want these projects to be completed. So that is the way we've traditionally done this. So I do understand valuable real estate. In theory, we can add more things. Obviously, we don't want to overwhelm, but if we think that there's something important that is not here that we can justify adding, we should feel confident in adding. Any other items or discussion for the capital?
Actually, now that I'm looking at it a little bit more carefully, what happened to the Ryan Clinic for translation services? That's more of an
That'll be on
expense.
an expense side, yeah, well, we're.
Yeah, I think but it's not on the expense, I think you have it
Yes,
on
yes,
the,
it is,
on the expense side?
yes,
Well, we're going to expense now.
yeah.
It's
Yes,
actually number 2 on the expense
yes,
side.
I probably pulled
there
it
it
the
is.
expense.
Yes, ma'am.
I gotcha.
I was too deep in
Got
the.
track.
Weeds.
That's a
Too
great
deep in the
transition,
weeds.
great transition to the expense.
Really.
So I'll just run down the expense, we have here. On the expense side, 9 items that, from last year. So we have the number 1, this has been a number 1 previously, expanding DHS street outreach, and, you know, this is a place where I think we discussed. It would be appropriate to flag things that would be heard program, and other interventions. The next, we have those translation services, we got a bunch of new data, we'll find another agency per your flag rule. We have HPD, increasing the funding and scope of the emergency repair program. This is addressing our repeated letters of things about, related to demolition by neglect. I think we've had at least 2 of those letters come out of the Hills Kitchen land use this past year, but we regularly have these letters, so
There's another 2 coming out this month.
That more color to the statement of district needs, unfortunately. We have a NYCHA staffing request, which is related to the capital. You know, it's a very similar vein of request, but this is staffing, so it is expense. We have the increase in delivered meals. And this is specifically for Hudson Guild, Project Find, Encore Community Services, the Stage Center Midtown, and Penn South. I am not certain if we have checked, I don't know if Maria has, we have heard from these entities as to, you know, whether or not they have these funding requests satisfied, but that might be something we just like follow up on. The next one is providing additional funding for housing attorneys, tenant organizers for housing conservation and coordinators, a community-based organization.
What was that response? This is not a budget request. Is that HPD's response to our?
They're saying they don't fund it, they're saying that organizations like that normally get their funding from donations.
Yeah, community organizations,
Yeah.
like not-for-profits or something.
So they don't consider this a budget request?
Yeah, HCC did come to us last year to specifically advocate for,
HPD funding a.
well, not HC, just for us to advocate for funding for more lawyers. So that was maybe we can just check with Tessie if there is another agency or route to getting it at least some attention, but again, having it here it's signaling for our electeds, even if there's discretionary budgeting, et cetera.
So we also have funding for education, prevention, and treatment for HIV, for GMHC, Ryan Health, Kind Word, housing. Pardon?
Just reading their responses there.
Yes, so I don't think that we have any particular like difference here, but we can, I think we've noted the piece for on Ryan that was funded. We might decide to check with the others on this one to see if those funding requests have been fulfilled. But I think that, you know, this has been a longstanding kind of need within the community, so we can, I don't know if it would, unless they've all been fulfilled, if there's any need to kind of move or replace them. There is a funding for supportive services for families that are currently in and soon to be exiting shelter. And this is I guess, an expansion of the existing programs. This is a request that I think we have had consistently here. I don't know if the funding is actually that extended. So those services, there's more demand for the services than is available. And then finally, the last thing that we have here is we have a like additional on-site or like supportive services for individuals and families to transition from shelter to permanent housing.
So if I recall last year, the response was also that they have already funded, but we noted that considering that we continue to see the strong need that we needed to ask again, because it's more services or more funding that's needed to keep up with the demand. And perhaps to keep them from responding in the same way, we maybe move these things up. And that's the only suggestion I have on this.
I think that's a brilliant thing, yeah, so we changed the wording, that even though this has already been funded, we see more need for
Even though it's
service.
expanded in the past, it needs to be even further
That's
expanded.
exactly, even though they were expanded in the past, because what we're saying is we want it funded for the need now. They're gonna just say, oh, well, you just asked for this is what we did last year, right? So,
So we're gonna change the wording then, or?
well, the wording gets changed every year.
We can change the wording. I think that's a
But
good
I
idea.
think, so specifically acknowledging it was expanded in the past, we think it should be expanded again.
Yeah.
Well, successfully.
I think you're right, expanding the past needs to be there, but also acknowledging the fact there's additional need.
Yes, good idea.
There's additional population that needs additional need in the area.
Building off the past success of the
Yeah.
funding that you gave, so the funding wasn't wasted.
Right.
Because Lord knows there's a lot of money that goes someplace.
Right, there are just so many more people.
Right.
Good point.
But I'm gonna propose again. That I think we should change the order of something here. And I think based on all of the meetings we've had this year, we should put the night shift repairs number one.
So I want to say, I want to acknowledge the fact that you all said that it doesn't matter what order we put them in,
I meant for capital,
for capital, okay.
because again, those would be the number ones to those agencies.
Gotcha.
On expense, we actually have a long list that are all going to the same agency in some cases.
Got it.
Yeah, that's, just wanted to.
All right. Then, yeah,
So anyway, I mean, we've just heard it every single meeting, people
No.
saying like how horrible it is.
Absolutely.
And so I really do think that this would. Help us be very responsive to what we've heard at every single meeting.
If that's the prism, which we will, I agree 100%, I second that motion.
Is
Well, yeah.
it a motion?
One place where I would attempt to disaggregate these two, would just be, in here, we're asking for funding for elevator repairs and mechanics. And you can correct me if you think that I am misidentifying the issue, but I believe that the issue we focused on within Chelsea land use and the housing committee has been primarily NYCHA's interim repairs for Hilton and Elliott Chelsea houses. And I think that the initial thought was, well, should NYCHA make those repairs, or is it the responsibility of related / Essence to help make those interim repairs as they, transition to this
Whatever they try to.
new development. And I do not know if there is. It is my impression that those two are not kind of overlapping issues, though I don't dispute that the elevator mechanics are very important. So I did want to see if that changes your perspective on the question. It might not.
Yeah, no, that's true, and you're right, and I guess I would like the request. I think our number one request should be. Repairs to, of longstanding NYCHA maintenance issues. And then maybe we could even say sort of including elevators, right? Like, so we're not getting rid of the elevator issue, but.
I think, I'm surprised, we did have 4 or 5 items 2 years ago that were specifically Fulton and Elliott, Chelsea housing.
I think that part of this, and I'm not certain, as to what removed them, but that this being the responsibility of the developer meant that this was not something that we were asking for from the government. Now, there is no one here to fact check me on it, so I can.
I mean, that sounds right, and I guess I would say, I don't know how we do this, like. The colloquial way of saying it is like, who cares? What we're saying is, whoever's responsibility it is, like, city, you need to figure out either by yourselves or with related assets. But this stuff needs to get done.
Well, and I think that will happen, because again, we're asking the agency, right? And it's irrelevant if there's also a private developer, because we're asking the agency to provide something.
To prioritize, making sure that it gets done by whoever it gets done by.
Jesse might be able to provide some clarity on why they dropped off. And then Katie's right, we've heard over and over again, we've also heard people that stood up and said, I don't have a problem, my apartment's there, so the experiences are varying, but we do know that there are problems, and it could be memorialized based on some of the letters that have come out of Chelsea land use.
Meets on Monday, so we will get a new set of items from them, so it may be a question of. Like the budget task force, do we slot that, is there a separate Chelsea land use item relating to internal repairs, and I don't know if they're.
Yeah, but it was still with the same agency.
Yes,
right,
right, so should that be a separate item, or should this be added on to the elevator item, and if they are repairs, then. Like this is a staffing request, then we would wanna go back to capital and have that conversation there.
I don't think it's a staffing request, I think they're talking about repairing the
It's
unit.
an expense, so the maintenance would be an expense.
It would be expense, we're not talking about.
The elevators,
For-
new elevators.
For the
would be capital.
maintenance of the various items that have been identified. Because capital. Yes, capital would be rebuilding the whole new unit, but what you're talking about is the testimony of issues.
I mean,
Ceilings falling
we have-
down, mold,
Doing the
We
actual work
have-
as opposed to buying the structure.
I mean, we have, in our capital requests, we have a variety of repair requests, and so typically our repair requests, we do put in capital. It is sort of a little bit irrelevant, I'm happy to like confirm that they belong in one place or the other. But my understanding is that if we, even though they're, internal repairs or small repairs, that they repair specifically or ultimately like work that goes to the unit, assuming we are funding the work to the unit, or we are asking for funding for work to the unit, that would still fall under capital. So I am happy to
find out more.
find out more, but two, to go back and add that. I guess it is a question of if you think that needs to go above any of our other NYCHA requests, because NYCHA, like if that is where that falls, NYCHA will see Harbor View before it will see the Fulton LA Chelsea items.
I think long-standing repairs should go above.
The internal repairs. Travis, did you want to say something?
Just since we, CB4 wrote a letter about it, and there was at least one, if not more, meetings about it. The building on West 57th. Any particular capital and or expense needs?
Yeah, but those are all developer issues. Everything there is stopped because they're waiting on HPD's decision on their applications.
Nothing in this present. Okay, fair enough.
They have the money.
So did that.
Yeah, thank you for asking. They have the money. It's just a matter of HPD making a decision and accepting their Q application.
So I'm gonna, now that we've had the conversation about the Fulton Elliott Chelsea interim repairs. I'm just looking at the list of capital items, it sounds like it would be appropriate to slot it after I'm gonna talk to Jesse and see where we are, if remains an appropriate request to be making to the city agency, because I understand that, we're seeing it as important enough that, if the city has to pay for it, the city has to pay for it, that people have been waiting for these repairs, but right after the second Harbor View request, so the long-standing Harbor View elevators and then various repairs, we would then have the FEC for interim repair request, and that would go ahead of the next DOHMH, HPD requests on that list if we're going in order.
I thought you wanted it to
I
go
wanted it to
number
go
one.
up.
You want it to go
That's
above?
number above affordable housing.
For that above part.
Oh, okay.
Yeah.
Sorry. Is there any dissent on that particular point from the committee? I think we're comfortable kind of moving there. I will touch base with Jesse and we'll touch base with Chelsea land use and just see how that works, but I think it certainly makes sense to add it as our number 4 first night for that.
A major change to our budget.
Now thinking about just going back to our expense order, do we have any additional expense items, or would we want to change the order of anything that we have on our expense budget?
Well, I guess I'm just wondering, given that our number 1 expense item right now is something that says it's already been funded, are we saying we want even more funding for that too, or are we moving it somewhere else because it's already been funded? Like, it doesn't seem like. I guess it's just a question.
Yeah, I mean, personal opinion, though, I think others are welcome to dissent, is we have, I think, often for a long time had the DHS outreach as a number 1 in expense, because despite the fact that a lot of money is and a lot of resources are spent doing this, I guess the problems like with street life and the interactions there persist, and so there is when you kind of read through the responses to the district needs survey or hear testimony at committees or full boards, a lot of it relates to the street environment, and the outreach would be helpful for that, but I don't know if you either disagree or believe that it would be helpful to move something else up in that service, but.
No, and it's funny, because look, obviously, I'm a huge proponent of all of the people doing street outreach need more funding. But I just don't know how effective it is as an advocacy position. Like, for example, we specifically asked for 15% more money to go to those programs, right? Breaking Ground, Goddard, BRC, and Urban Pathways. And then they say it's already been funded. Really? So are they saying that all 4 of those agencies already got 15% more?
Again, sometimes when they say already funded is just like saying like it's not our agency, it's a standard answer. And that's why even if that's their response, if we know it's still the need or there's additional need, as Travis was saying, there's a new need.
Yeah, so,
Yeah,
I guess I would say let's leave that as number 1, but maybe change the wording a little bit to say like, given the,
increased
needs or continued needs on the
influx,
streets,
or whatever,
we think that street outreach needs increased funding, about 15%, yeah.
Absolutely.
Okay. Yeah. And I guess actually the second one there, which is about Ryan Chelsea Health and the translation services. I mean, they gave us specific numbers tonight, right? Didn't they say it went from
3,000 to 17,000.
right? So I think let's throw on the facts, seriously, they really need more. What was that language they said?
Wallet.
Well,
Language often spoken in Senegal.
Mauritania is the main country that speaks it.
How is that spelled?
Mauritania, it's north of Senegal.
We've done the right? So then I guess your question is, are we wanting to change anything else?
And that is.
I mean, it'll all be debated again.
Yes. Which you're welcome to join. It is Wednesday at 6 p.m. is the budget first meeting. But is there anything else that should be added, should be changed here?
The needs are the same, the language on how we word it may have to be adjusted, but we still have the same needs.
I'm trying to remember, when we did our City of Yes response about housing. Was there anything we identified there that would be at all capital or expense related?
We were specifically responding to the proposals, so we were talking about what work that, I don't recall us advocating for something that would need, we can ask the Department of City Planning to go ahead and go back to the drawing board. That could be something that we can ask as an expense, but no, I don't think that in that letter, I don't recall that we asked for anything. I think we were just responding to all the various proposals.
And I think there were some like, if this, then you should fund this. You.
That's what I was
Then
thinking,
you should
exactly.
do that, but they haven't done anything yet. And we requested that, but we're not, it's sort of like amorphous and vague. And I wouldn't necessarily think it would be as helpful to make that request.
But we don't have to vote on this.
In fact, we can.
Right.
So
We're not able to vote, and I needed to leave 10 minutes ago.
So fine, it's been nice knowing.
I would like if we could wrap up. So
I
walk
don't
out.
believe that we have any further business for the statement of district needs. Now, I will make sure that there is some items like of this conversation that are circulated. It'll probably go through the budget task force. I can write up what we have here and Maria as well. And we can make sure that that is publicly seen to the committee. There will also be an opportunity when it comes out of the budget task force to comment further, so if you believe that something's been miscommunicated or being captured right, like, please let us know and we'll make it right. But with that, I would like to make a motion to adjourn this meeting.
Second.
Paul seconded too, so that's good.
Thank you. Thank you.
Meeting adjourned. Thank you, Nellie.
It wasn't that bad.
Good night, everyone.
Good night, thank you.